Hi, everyone. Thanks for coming in. Last session of the day. Woo, hanging in there. It's hard hanging the whole time. It makes for a long couple of days, right? So hopefully this talk will be kind of fun. It can be really dry, right? Talking about headaches, but my medical assistant, I treat a lot of people who have chronic migraine headaches. Um, I offer Botox injections in my setting. A few years ago, I saw a need in the community, and I'm like, why can't people get this treatment? Um, and so I thought, well, why not? Why not train and do it? So I do. It's a really fun thing to do. I'll talk a little bit more about the procedure. Not really something that primary care providers are doing. The authorization process is a real pain, that sort of stuff. But my medical assistant compares people with migraine headaches to patients who have like overwhelming kind of centralized pain syndromes, like fibromyalgia or complex regional pain syndrome. Those people are kind of overwhelmed by their pain and their body sensations. And so my medical assistant is like, this is like fibromyalgia in the head. And I would agree with her. It's really overwhelming for people. And I honestly can't imagine having head pain every single day. I'm a person, I get a lot of headaches, but not many migraines, thankfully. But some of these patients I meet with a migraine headache, debilitating every day. I just cannot imagine being that person. So we have some objectives. Boy, I was an overachiever here on our course objectives today. But I'm going to do a lot of pharmacology too in this particular talk, because there is a lot of pharmacology that's helpful and some not so helpful for treating head pain. These you guys will likely learn, hopefully, at the end of this talk. So first of all, we're just going to talk about the impact of headaches in adults. Real common reason for primary care visits. Those of you working in primary care probably know that. The latest numbers are about 14 to 16% of adults in the US are affected by migraines in some way. And these result in a significant work absence and impaired daily function. If you've ever worked side by side, or even you personally, with somebody who struggles with chronic migraines, these folks miss a lot of work. They're kind of looked at with a side eye at work, like, oh, she's out again, that sort of thing. My first contact with somebody that was a frequent migraineur was I worked in a front office with a lady at the university many, many moons ago. And I could look at her and I'd be like, oh, you're having a headache, aren't you? And sometimes she couldn't even talk to me. And that's when I knew I kept her husband's phone number at my desk, and I would call her husband to come pick her up because she just could not even function. She couldn't move, nothing. When she was there, she worked really hard and was great, but these migraines were terrible for her. So headache history, right? I think as clinicians, we all struggle to collect the recommended history on things, right? But the history is really, really important, especially when you get a person who has kind of walked down the line of different treatments and you need to sort of go to more, I always tell my patients that it's time to do some college classes for your for your migraine headaches or your headaches. And so when it's time for those college classes, you have to make sure that you've demonstrated that they've walked through kindergarten to 12th grade, right? So you need the onset, right? Is this an old or a new problem? Totally different perspective if this is a brand new problem, right? If you have somebody over the age of 50 with a new onset, really bad headaches, what are you going to do? You're going to image really soon, right? You're going to do extra screening. And then when it's somebody who is, I've been having migraine headaches ever since I was 25. I've seen 14 neurologists. Nobody can seem to get to the bottom of this, right? I've had imaging. They told me everything was normal. Very different. So onset is really important here. Duration. How long does an untreated headache last, right? If your untreated headache is only a couple of hours long versus 4 hours or more, the 4 hours or more is a feature of migraine headaches is that 4 hours or greater. It doesn't prove migraine, but it is definitely a feature. So you want to know, if you don't do anything, how long is your migraine going to last, or your headache? Is it going to be day on day on day, or is it just a short time? Frequency. You want to know if something really, in terms of determining chronic versus episodic headache, you want to determine if you have less than or greater than 15 headache days in a 30-day period. Okay, so about half of the time. Now, sometimes it's tricky to document frequency because I'll have patients come to me for migraine pain, and I have a nice little piece of paper that I have them fill out. So when I get in the room, I can quickly look at that paper and be like, okay, I know what we're dealing with. But sometimes the frequency, they'll put, how many migraine days do you have in a month? And they'll put 3. I'll say, 3? That's not so bad, right? I mean, that's not great, but that's not horrible. And so then I have another question that says, how many days do you have no head pain? How many days a month? And they'll put 0. I'm like, so what about the other 27 days? What's going on for you? Well, I have head pain, but I'm not vomiting. I'm able to get out of bed on those other days. And it's like, oh, well, you're having migraines maybe every single day. Some are mild, some put you to bed. So asking the opposite sometimes will give you a better idea. And I'll say to people sometimes when they don't seem to understand that I'm trying to do the math, I'll say, so think of over the past 1 month, how many days did you wake up with no head pain, and when you went to bed, you had no head pain? How many days did that happen? And that sometimes will be like, well, 2. Okay, now we know what we're talking about. So really, you do have to noodle that out and don't just take it on the surface, because some people will figure that some headaches are not worth reporting, but they are, right? They're all important. And then let's see. Then also pain characteristics. Okay, so here's where we're going to find some features of migraine versus not migraine. I don't know if I said it in this lecture. I might have a slide on this later. I don't know, but you want to differentiate migraine features versus non-migrainous features, because migraines are actually hugely underdiagnosed. Some people feel like they have to be vomiting and in bed for it to be a migraine. But really, if you look at the pain characteristics, throbbing versus not throbbing, a throbbing headache, it's a migraine. Okay, not throbbing is not a migraine. So that's a really easy tell. Sharp, dull, and burning. The sharp and burning are migraine features. The dull, not so much. Tightness, that's plus or minus. Unilateral pain versus bilateral pain is a migraine feature. So if you have somebody with unilateral, can change sides sometimes. Unilateral pain that's throbbing, you probably have a migraine. Let's see, triggers, there's environmental, foods, alcohol. Some people can find their triggers for you. Other people cannot. They're not quite sure. But there's certain foods that tend to trigger migraines for people. So if you're working with somebody early on with migraine control, you can try to experiment with some foods. I have a daughter that if she drinks red wine in the United States, migraine for sure. But the red wines in like Europe don't do that because they have a different process. Anyway, but there's things like hard cheeses and that sort of thing sometimes for people. But there's a whole list. I didn't put it in here because I figured we couldn't spend a ton of time on that. So history, again, associated symptoms. Okay, so aura is typically associated with migraine headaches. And aura often shows up as a visual change. People will say they have, wavy lines or jagged lines or lightning bolt sort of things. Some people have colors in their aura. There was a nun in I think the 1500s, I forget her name, who actually artistically drew her auras. And I think they thought she was possessed or something. But anyway, she drew her auras. If you Google that, it's pretty interesting to see what she drew. Nausea and vomiting, that's usually associated with migraine headaches. Photophobia and phonophobia. Okay, if you've got the photophobia and phonophobia with somebody, if they say, oh, I go to a dark room and have to like close everything out, that is very much associated with migraine headaches. And so that, you know, if you've got the photophobia, phonophobia, and throbbing, you know, boom, it's a migraine. Even if sometimes they're not in bed with it, if those features are there, it's a migraine. So don't be afraid to diagnose a migraine on these criteria that's migraine. So impact on function, that's really important if you're going to start asking the insurance company to cover some of the more expensive, newer medications. How often are you missing work, school, social activities, time with family and friends? How often are you just going to a dark room? Right, people do have to unplug from their lives with head pain. So with your examination, so you can see there's a lot of stuff in the history, but with your examination, you definitely want to do, you're really doing a neurological exam, right? Is your most important thing, because you want to look at those pupils, you want to look at their gaze, all of that. But mental status, do their cranial nerves, the ones that you can do in the office, motor system, right? Their coordination, reflexes, their gait, sensory system. Okay, so you don't have to get really super duper fancy with their exam, but you want to be reassured that there's nothing going on that's a red flag, right? That's suggestive of a serious condition. Sudden onset or a thunderclap headache. Okay, that is an emergency. Neurological deficits. Okay, so if you're looking at anything neurologically that doesn't look right, it's really going to send you over to wanting to get some imaging on the patient. Systemic symptoms, right? A fever, malaise, that sort of thing are your red flags. Because, you know, to be honest, when I evaluate somebody for a migraine, if it's something that's chronic that they've had for a very, very long time, their neurological exam is reassuring. Okay, there's nothing on there. I typically don't run right to imaging. You know, why would I do that if I don't have an otherwise compelling reason? If this thing looks and feels and acts like a migraine, they've been told they have had migraines for the past 15 years, you know, why am I going to rush them to imaging the day that they come see me? You know, what's special about that day? So if I can't really justify that imaging, I don't do it unless, you know, something changes and I feel like they have some symptoms that, you know, might warrant the imaging. So differentiation, okay, so this is a better, more information about differentiating between migraine and tension headaches. Now, there's 4 types of primary headaches according to there's a headache group here, this ICHD, and I can't remember what they stand for. But anyway, the migraine and tension type headaches we're going to talk about. We're not going to talk about trigeminal autonomic cephalalgias or the other oddball primary. I'll list them, but we're not going to really talk about it in this talk today because that's more a neuro talk and much more information. So migraines, head pain is one feature of a migraine. Okay, so tension headaches is typically the headache is the pain. That's like the feature of a tension headache most of the time. There's a little bit more to it, but migraine, one of the throbbing or pulsing pain, unilateral pain, nausea, photophobia and phonophobia, aura sometimes. And the head pain lasts greater than 4 hours. So episodic migraines are less than 15 a month and chronic are greater than 15 a month. And just don't forget how to try to evaluate and get that information out of people because, you know, it makes a difference if somebody says that they're having 3 headaches a month, you know, using a medication that they only get 9 pills a month might be appropriate, right? But if they're getting 25 headaches a month, you know, when do they use their 9 pills? You know, anyway, tension type headaches, mild to moderate pain that does tend to not be as severe as migraines, tight band feeling around the head. So often they'll describe that, although I've had people have a tight band type headache with migraines too. So that's not 100%. Dull and aching usually. It doesn't usually have a sharp pain. Tenderness in the scalp, sometimes neck and shoulder muscles. Sometimes it seems muscular if you palpate the scalp while they're having a headache, or if they palpate their own scalp while they're having a headache sometimes. Those tension type headaches are like that. And again, we have chronic and episodic, right? And so trigeminal autonomic cephalalgias, those are the different types of headaches. Here, not going to spend a long time on it, although cluster headaches, I'd say you see a few, but often those are they're sexy enough for the neurologist want to see people with cluster headaches. Migraines, the neurologists are less excited about. Other primary type headaches, I didn't know there were so many, but there's an awful lot of them. So here they are listed for you, but not anything we really are putting in this talk today. So we have medications. So let's get into the nerdiness with medications. We have two types, right? Abortive medications and preventive medications. So abortive medications are to take episodically at the onset of a migraine, okay? So you get the head pain, you take a medication, and hopefully your head pain will go away. Those are abortive medications. Preventive medications are ones that you take on a regular basis to try to prevent or cut down on the number of headaches or migraines that you have. So here's some abortive medicines, right? We have our NSAIDs, acetaminophen, triptans, CGRP meds, opioids, barbiturates, and so NSAIDs, this is first line, okay? Now we're talking about preventive for migraines or really any headaches. I'm sorry, not preventive, they're for episodic headaches. Ibuprofen, of course, naproxen, aspirin, there's more, right? There's a ton of NSAIDs out there. I don't find that one NSAID works any better than the next one, to be honest with you, but some people do. So it's okay to try some different NSAIDs. And some people feel like a prescription NSAID is just going to be better than a non-prescription NSAID, but really the numbers are not any better for a prescription versus a non-prescription. And I'm of the thought process, less is more, right? So I'm kind of more into less medicine for people. So risks of NSAIDs, of course, are the GI side effects, right? The gastritis, bleeding, especially if taken chronically. I've had some people with, their kidneys are not enjoying being stepped on by the NSAIDs. And so you have to, really, really keep an eye on folks. Just because something's over the counter doesn't mean it's completely harmless, right? You all know that. Cardiovascular risk. Somebody hypertensive, asthmatic, that sort of thing, you kind of have to really, get the side eye to the NSAIDs. There is a risk of medication overuse headache. So if somebody is taking an NSAID every single day or multiple times a day, they will most definitely get rebound headacheing. And what cures the rebound? Another dose of NSAIDs. They get in these really, really horrible cycles this way. Well, I can't function if I don't take the med. And it's like, well, you got to go through this, and let your body adjust. But it's really difficult to get people off of NSAIDs when they're overusing them like that. Acetaminophen, again, first line, it's hepatotoxic, right, at high doses. Tends to be less effective than NSAIDs for acute migraines, although my very favorite, even for any ache or pain, is a single ibuprofen and a single acetaminophen together. There's a publication from 2010 published by a fellow named Teeter, and I think it's the efficacy of pain medicine. And I can see this graph, a graph in that document that shows, compares different pain medications side by side. And they were treating post-surgical pain. And the group of people taking a single ibuprofen with a single Tylenol actually did better than the group of people taking 15 milligrams of oxycodone. This was, kind of unrelated, but that article blew my mind. Like, I couldn't believe it. And so I actually will recommend taking the single of each pill. It's 500 milligrams of ibuprofen, of Tylenol, and 200 of ibuprofen taken together, and that keeps everything low dose, and they can take that up to 6 times a day if they need it. But not that I would want them to do that for headaches, because they're going to rebound again, right? So acetaminophen is better for those with contraindications for NSAIDs. Sometimes can help, but again, it's a wicked rebounder, so you don't want people taking this multiple times a day. Combos, right? So that Advil Duo, I don't know the dosing on the Advil Duo. That's a name brand, by the way. That's got ibuprofen and acetaminophen in it. So that little combo I was talking about is this Advil Duo. But I don't remember the dosing on the actual pill, so you'd have to double check that. Excedrin, oh, people with migraines, they love their Excedrin. And I would say Excedrin is the worst rebounder ever. It's love-hate, right? Because people who get an episodic migraine can take some Excedrin migraine, and they can do really, really well with this. But it's people who are like taking it day on day on day and multiple times a day. They have a wicked time getting off this if they're rebounding. Let's say risks, same, with other NSAIDs and acetaminophen. And Excedrin also has caffeine. I believe the NSAID in Excedrin is aspirin, I believe. But anyway, risks with Excedrin: insomnia, palpitations, of course, the GI upset, and more. Okay, so there are some risks to that medicine. And then the overuse headaches, right? So moving on, triptans, okay, these are tried and true. These are selective serotonin receptor agonists that target these receptors here. And here's just list. I think I listed them all here, but sumatriptan comes in oral formulations, but also subcutaneous and nasal spray. So some people who have the feature of a lot of nausea and vomiting cannot tolerate taking a pill, swallowing a tablet and keeping it down. So sometimes that's handy to have a different delivery method. And again, the triptans are for episodic migraines, okay? These are not for somebody migraining every day or every other day. The rizatriptan orally disintegrating tablet, so the ODT, meaning they can pop it in, they don't need to take it with any water, and often is better tolerated than just a pill with water. Zolmitriptan, there's oral nasal spray, ODT, naratriptan, almotriptan, elatriptan, fovatriptan. So you see that. There's a lot of triptans. And sometimes in that person with the episodic headache, if for whatever reason sumatriptan doesn't agree with them, it's okay to try a different triptan. Sometimes you will get effectiveness when one of the others does not work. Tricky part can be sometimes the insurance company will have some preferences for one drug or another. And you don't know that until you prescribe it, and then you get a request for a PA, and the letter saying, no, we don't want to pay for that, but we'll pay for these things. It's trial and error all the time. But the triptans, don't be afraid to go on and try a different triptan if the first one is not helpful to the person. So triptans are usually effective within the 2 hours of taking it. There are multiple formulations, like I just said. Side effects. Sometimes people take a triptan and they've got to go lay down. So they take a triptan and don't get their day back often, but it does relieve the pain. But dizziness, fatigue, some chest pain sometimes, paresthesia, serious cardiovascular events can happen. So I am really, I'm very hairy about giving a triptan to somebody who's got a lot of cardiovascular history, ischemic heart disease, uncontrolled hypertension, even controlled hypertension. I'm still a little like, hemiplegic migraine is a different type of migraine that a triptan is not indicated for. This is risk of medication overuse headaches. Way back when I was first starting to treat migraines, I had a lady, just terrible, intractable migraines, terrible. And at the time, I didn't have as many nice chronic medicines as we've got now. And so I'm like, well, what if I put her on a triptan every day? It took me forever to get her insurance to agree to it, and we tried it as an experiment. It helped her for like a month and a half, and then we were in the same boat again. So my experiment was sort of a flop. So CGRP, receptor agonists, okay? These are the kind of the new kids on the block. They're not really that new anymore, right? I don't know how long we've had them, but for a while. Calcitonin gene-related peptide receptor agonists, known as GPANTs, or I don't know if that's what everybody else calls them, but anyway. Rimegepant is name brand Nurtec. Ubrogepant is Ubrelvy. These are, again, we're still in the episodic migraines, okay, not preventive yet. These are safer than triptans as far as not contraindicated in people with heart disease. And they're also side effects are sometimes nausea, which you get that with a migraine anyway. Some people feel sleepy, but look at that, 2.1% of somnolence, right? Very low incidence of that. Some dry mouth. So really, a lot of people can take a CGRP medication and still work that day. You know, then they don't miss work, they don't miss their life, which is kind of nice. And so these are both oral as well. They're really pricey, by the way, because they are still name brand. But if you've tried and failed other things, or other things are not indicated, if they're contraindicated, you may be able to make an argument with the insurance company, right? Because I prescribe these things all the time, get them approved, but you've got to learn to speak the language. Did somebody yesterday say something like we work for the insurance company? Yikes. But it kind of is, you know, to get our patients what they need, we've got to speak the language. Yeah, their brand, they're expensive, prior auth. Sometimes a copay, even with a prior auth, is horrible. But they do have, if the person has commercial insurance, they do have the copay assistance cards, because these guys are name brand still. So you can get the copay help. Of course, your patients who have Medicaid or Medicare, no way. You know, if it's straight out Medicare, you're not going to get the copay assistance, and it's a crapshoot, you know, depending on what their drug coverage looks like. So you might end up like, you know, with these ones sometimes. So Ubrogepant, 50 to 100 milligrams by mouth, PRN for acute treatment of migraine. If needed, with this one, you can take a second dose at least 2 hours after the initial dose if you need that second one, not to exceed 200 milligrams in 24 hours. The Rimegepant comes in a 75 milligram tablet, PO, as needed for acute treatment of migraine, and no additional doses in 24 hours. Okay, so this one's one and done. If it doesn't work, then yikes, you know, but these do tend to be pretty effective. I've seen some good things coming out of these two. Typical monthly prescription for these are 8 to 16 tablets, depending on the insurance. But so they're going to have some quantity limits, and I think a lot of them come in like an 8 pill blister pack kind of thing. So you'll learn that too, right? The pharmacy will be like, I can't give you 9 pills, I can give you 8. So you just kind of learn these things on the fly, right? It's like, oh, well, I don't know that. So opioids and barbiturates. Opioids as a class of medication is not indicated for the management of migraines. Not that you will occasionally see people who are managing their migraines with an opioid medication, but it's not indicated, and you would be giving them the latest best care, if they are on opioids, is finding something different to help them control their migraines and getting them off that high risk med. Butalbital containing medications, okay, this is your barbiturates, are also not a first line therapy for the treatment of migraines, although you'll see a lot of people who are on the butalbital medications. Now, you know, I don't die on that hill if somebody is on a butalbital containing medication and they take 3 pills a year. You know, it's like those folks who get like one prescription every once in a blue moon. I don't get too freaked out about it. It's the people who are taking like 2 of these pills 3 times a day, every day, that I freak out about. Like, we can't do that. Don't abruptly discontinue something with butalbital if they're taking it every single day. You want to definitely taper it out and pretend it's like an opioid, benzo-ish kind of thing. And they will struggle with this. But often you'll be getting some rebounding going on with these butalbital because they almost always have acetaminophen in them. And I actually think the butalbital itself will rebound people. It's not intended to be used as a chronic everyday medicine, multiple pills a day. That's excessive. But anyway, you kind of have to make that judgment yourself. I had a neurologist say to me one time, don't prescribe Fura anything. And it's so, I kind of took that to heart, but then when I really looked at it, it's like, yeah, I don't want to be prescribing butalbital for somebody to take every single day. But if you've got somebody in a real crisis, it can break up that kind of crisis migraine for them. So both of these are prone to dependence, okay? So something you can't just abruptly discontinue, and rebound headaches. And there is a risk for misuse, not that that's our number one reason. It's more the number one reason to try to get somebody moved to other treatment is that other treatments are first line, and are far safer for them. So preventive medication. So this is kind of fun and kind of my shtick, when people are in the chronic migraine realm, what do? You don't treat these things episodically, but a lot of people just try to get by with episodic medications. So we have some natural remedies, and I'll give you what I typically use and what's in the literature. Anti-seizure medications, antidepressants, blood pressure medicines, the CGRP receptor agonists. See, those are showing up again in preventative stuff. And we'll talk a little bit about Botox. I put that in the end because that's not something you'll do, but it's something your patients might have done. So you kind of will want to know how that goes. So natural remedies, right? We have magnesium is effective, particularly for menstrually related migraines and in children. So in your peds patients, so you can MAG. MAG, you've got to watch for diarrhea, right? So don't overdo the MAG, or somebody can get some loose stools and they'll be like, I don't know why I have this. It's like, well, I had magnesium. And it's funny because somebody was recommending MAG to me for hot flashes too. So there's got to be some hormonal elements to magnesium that I don't fully understand. But anyway, B2, riboflavin, this significantly decreased the frequency of migraines in the study group. CoQ10. This was a small randomized controlled trial, but you'll see some people take that for the migraines. Butterbur, it is effective in reducing frequency, but there's a pyrrolizidine, I'm not going to say that right by any stretch, alkaloids, due to risk of hepatotoxic effects. So I guess there's a form of butterbur that maybe is not so nifty. So that, I don't recommend butterbur, but I know people will look it up and take it themselves. So you want to make sure whatever this P word is, alkaloids, you don't want it to have that in the butterbur. Feverfew, there's mixed evidence for effectiveness, and melatonin, there's emerging evidence for effectiveness. Melatonin has some anti-inflammatory properties too, so it might be that's helpful. This is my typical recommendation. I have this as a like little quick text for my charts. I'll drop this in here with this combination. There's also Migrelief that has most of this in it. It does not have melatonin in it, though. I can't remember if it's got the rest of it in there. And I tell people, listen, if you're not the type of person to buy all these supplements, take them consistently for 6 months, don't waste your money, right? Like, you've got to dig in and be there for 6 months with this, because sometimes it doesn't even start working until that long a period of time has gone by. Yeah. Oh, the question was, is there a specific type of magnesium I recommend? And no, I don't recommend that, but I think that there's one of the two that are regularly available. One of them tends to be less of a diarrhea causing formulation. So I can't remember which way that goes, but glycinate. See, everybody in the crowd knew. Thank you, guys. But anyway, so yeah, it doesn't, all of the literature I see, I don't think it specified which form of MAG. And so that's the natural remedies, and people love this when you drop this in and say, hey, maybe you should try this. And I have actually seen people kind of cure their migraines with this, or mostly cure. Do you want me to go back so you can get that picture? There you go. So natural remedies, mind-body therapies are definitely first line. Mindfulness meditation. Now, nothing is gonna anger people who have bad chronic pain than telling them you need to be more mindful. So tread lightly, make sure that that is something that you have resources for, and that your person is able to hear and not feel like you're minimizing what's going on for them, right? But this may be as effective for medication overuse headaches. So I think that this is where you can really make some progress with those medication overuse, because I have people that, boy, oh boy, they have a hard time getting off medications. Yoga and Tai Chi, these modalities reported to increase quality of life. These things are good no matter what's going on for you, right? But I tell people, if I think that yoga and Tai Chi would be helpful for them, I tell them, hop on YouTube, look at these things. People love to show you what they're doing. Try a few things and don't spend any money until you think that this is something that suits you, right? Manual therapies like acupuncture. They had a little study that said, well, acupuncture worked better than sham acupuncture. So real acupuncture works better than fake. And here in Maine, I think there's a few places where you can get affordable acupuncture. There is a place called Down East Community Acupuncture. And she's on Verona Island, and she has a pay what you can afford policy. So if people want to take a drive to Verona Island, what my patients have told me, she has you leave your money in an envelope and in a basket. She doesn't even know how much you paid. So she's pretty nifty. She gets good healing juju, but you could be in a room with 3 other people being treated all together, right? That's how she makes ends meet. But she does some stuff for like PTSD too. So she's a pretty nifty person. Down East Community Acupuncture. So those things can all be helpful, because some people are like, I do not want to take a pill, thanks. And that's okay. So here come the pills though, right? There's a lot of preventive pills. A lot of these medications we have like the super old and we have like the super young medicines, right? So we have stuff that's been around forever that we've used, and then we've got stuff that has a fewer years on the market. But the anti-seizure, okay, topiramate, doses range from 50 to 200 milligrams a day. You can split it up, you can once a day. Significant reduction in migraine frequency if your patient can tolerate the medicine, right? Topiramate is nicknamed Dopamax for a reason, because people feel very dopey on it. Relative sedation. Don't forget, your people who get kidney stones, you want to be really, really careful because it can increase the risk of kidney stones. So if I have somebody who's ever had a kidney stone, I'm not going to put them on topiramate. Interacts with oral contraceptives, makes those less effective. So you want to be really careful with that. So that sort of eliminates a big population. If you have somebody who is underweight, okay, or has an eating disorder, you definitely do not want to use topiramate because it reduces appetite. If you have somebody who's chubby and would like to have a little help with their appetite, topiramate might be a good choice. You might get a 2-for-1 deal. But that's if they can tolerate it. It's some people do. I think it's a miracle when they tolerate that medicine. I'm just like, holy cow, that's pretty cool. Divalproex sodium and sodium valproate. These are also effective, but usually not used. They can have hepatotoxic effects and risk of weight gain. I never use these. I just don't. We have so many other options that I don't, but it's in the literature. So, and you might also inherit somebody who's on these already. Gabapentin, lamotrigine, carbazepine have not demonstrated effectiveness, although you'll see people on gabapentin. I'd have to say, I think I've put a couple people on gabapentin. Because I can't use topiramate for whatever reason. I'm not using the others. I have tried it just to kind of satisfy insurances too, that yes, they've been on anti-seizure medicine. And I actually did have one person get better on gabapentin in 15 years. Not bad, right? Antidepressants. So amitriptyline and nortriptyline, these have good good evidence for effectiveness. Usually 10 to 50 milligrams at bedtime. It can do double duty, right, for people who have insomnia. However, these are highly anticholinergic. These are on the Beers list, so I hate to give somebody a medication and say, oh, poof, you're 65, I can't give you this medicine anymore, or shouldn't give you this medicine anymore. So, am I in love with the TCAs? Not greatly, but I will use them from time to time. And sometimes people will come to me already on them because they're somewhat effective for them. Venlafaxine, this is an SNRI. This is significantly effective, usually up to about 150 milligrams a day, although I've pushed it to 225 from time to time. GI side effects are the most common. You could consider duloxetine too if the venlafaxine isn't your jam. But in one of our talks yesterday, they were talking about getting people off of these SNRIs. It can be brutal. I've even if somebody needs to come off them, because I have had like one person who was doing really well on venlafaxine, all of a sudden her liver enzymes went whoop, and I'm like, what the heck? And the only thing I could think of was the venlafaxine. Sure enough, but we had a hard time. I had to put her on some low dose Prozac to get her off the venlafaxine. It was really grueling for her, really hard on her body. SSRIs, the studies did not reveal effectiveness for this class of medicine. So really kind of how I practice is if somebody's on an SSRI for their depression and they're doing well, right? They're stable and their depression is doing well. I normally would not say, hey, let's change you over to venlafaxine instead of your antidepressant that's working really well. I kind of will leave that alone. And move on to other things because we have other options now. And I would hate to destabilize their depression, right? If they're doing well, you can kind of muck things up if you try to make a change when they're really, really stable on a certain antidepressant. But that's just me, right? Other people are more adventurous in that way. Blood pressure medications, your beta-adrenergic blockers, metoprolol and propranolol. There's good evidence of effectiveness, but of course you have your risk of hypotension. They can be a bit of weight gainer, so careful, for some people. And so some folks I can't put on a blood pressure medicine at all because their pressure is too soft at baseline. I'm not going to go there. Why make somebody fall on their face? So your angiotensin 2 receptor blockers, candesartan, this shows promise, but it's not considered first line. So I've never prescribed that one myself. Calcium channel blockers, verapamil, this is well studied, but the efficacy is less well established. So, typically if I'm going to go into a blood pressure medicine, I typically will use propranolol. Start low, go slow. There's, you'll look into UpToDate and it'll be, this many milligrams, and it's a lot for migraine prevention, but I will usually start them on the tiniest little dose and kind of assess for tolerability before I start pushing the dose up at all. If somebody has concurrent hypertension, sometimes it can help their hypertension. Which is nice. So your CGRP receptor agonists, okay, these are pretty nifty. So we have atogepant. I'm gonna really butcher these generics, right? Also known as Qulipta. This is a PO formulation of a preventive medicine. I've only I've only prescribed this for one person, and she was started on this medication through a neurologist because from time to time, the insurance companies will push back on me and say, hey, you're not a neurologist. This needs to be prescribed in conjunction with a neurologist, which really is irritating. It kind of gets my hackles up when that happens. But some insurances are like, yeah, too bad. And so I usually will I have a neurologist, and actually I found out she's leaving the practice, so I'm devastated. But she used to do a televisit with my patients. She would squeeze people in to do a quick televisit to tell the insurance company, yeah, do what she said. Which is kind of ridiculous. And if she disagreed, she'd always be like, yeah, well, I think you didn't do this one first or whatever. But almost always she'd be like, yeah, I think that's the next logical step. With some of these medications, if it says it needs to be done with a conjunction of a neurologist, I get really bummed out because under normal circumstances, our patients are waiting what? I don't know if it's how many months now? 6 at least, yeah. Which is just not cool, but that's better. I mean, it has been like 12 months for some places. So Rimidipant, this one I have gotten prescribed or approved through the insurance company. Now, this is one of the acute medications too. So this is the only one here that's used for acute and chronic. And for chronic, you're taking it 75 milligrams every other day. Kind of cool. So that eight pill pack, you want them to get 2 of them per month, right? That's 16 for 32 days. And they take a pill every other day, and they can have it as a preventive medication. Again, it's going to need a PA. It's a brand name. It's hugely expensive. But if you've tried all of these other things and you provide that history to the insurance company, often you can get this approved. And then the next 3 on here, the Arenumab, the Fremenuzab, and Galcinezumab. I should have asked Google to pronounce these for me before this talk, but I didn't do it. I usually say it by the name brands, but I know we're supposed to not do it. But anyway, those are all monthly sub-Q injections. They come in an auto injector, so they're a little pen. Most patients are pretty comfy doing this. Like I'm always like, all right, so look at the package insert. If you're feeling wiggly about it, your pharmacist can help you, or call us up and we can do your first injection in the office, and I'll have an MA work with you or a nurse or somebody. And most people are like, oh no, I got this, because it is just a little pen and subcutaneous tissue. The name brand Ajovi, the Fremenuzab map. That one can be once a month, or also they can give themselves 3 injections every 3 months. And so that's pretty nifty. I've only just recently prescribed it that way, 3 shots every 3 months in a patient who was on a different one of these once a month, and things sort of wore off, and I did have to get some help from neurology, and they said, hey, this loading up at every 3 months might actually be helpful for her. So we decided to try it. So I don't know, the jury's out on that. But for convenience, some people might be like, yeah, 3 shots 1 month, and here I go, do that 4 times a year. So anyway, I don't have any particular preference of which one of these. Often the insurance company will tell you which one they want you to use. So there's a favorable side effect profile. Again, these aren't really, they're not sedating. Some reports of constipation, some reports of some GI effects, injection site reactions for the sub-Q medications. Now, alopecia. We've had a few reports, about 7% of people report some hair thinning. So that is not going to be a popular thing for people. So just kind of watch things, right? If they already have like really thin hair or thinning hair for other reasons, you may want to think about these medicines, or at least forewarn somebody. Rare AFib and MI has been reported with these, but really rare. Like I haven't had any bad reactions. I've had a few people who don't tolerate it, and they're more like an allergy type reaction. Like I got a rash, and then I got a worse rash, and it's like, oh, stop taking that, please. So now we're going to talk about some more advanced stuff. Okay, so this is, probably not going to come through the primary care office, but you may read this from your headache specialist, your neurologist. So this one, actinizumab and whatever JJMR is, brand name Vyepti, I'm sorry, is an IV infusion every 3 months. So it's 4 times a year. This could cause or worsen hypertension, which would then fall back on the primary care provider, right? If all of a sudden their hypertension is out of control. Hypersensitivity, of course, can happen, and there's a risk of Raynaud's, which is an interesting risk with that. The class of this, I'm pretty sure, is CGRP. I forgot to double check that. Sorry about that. But I would put myself 99.9% certain that it is a CGRP medication. So Botox, we'll talk about Botox for just a couple minutes, and then we'll have hopefully 5 minutes for some questions, if anything. So Botox, this has been approved since 2010. So we've had Botox around for a long time for the treatment of chronic migraines. The goal of treatment is a 50% improvement in frequency and or intensity. So I tell patients that your insurance company is going to want to hear me say those words. So you've got to tell me, if it's some combination of frequency and intensity, because some people will say, yes, it has reduced my headaches, and the headaches I do have now, my abortive medications work. And that's a huge deal. And then used in the setting of chronic and not episodic migraines. Okay, so this is for your chronic migraine people. You need to have more than 15 headache days a month. Headache day, or more than 8 are considered migraine days, although almost always, if somebody's migraining, they're all migraines, but, and greater than 4 hours per episode. Now this gives you, this is kind of tiny. Is this the pointer? Yeah. So this is kind of tiny, but it's targeted at different places. You can see these little dots here, right? So there's 1, 2, 3 here, and there's, and those are the others here, but so it's 5 units in each site, and there's 31 sites. So it's 155 units, which people who do cosmetic Botox go, holy God, right? But Botox, you can have up to, I think it's like 400 units a month your body can have. So there's no way, even if somebody's also getting cosmetic Botox, that you're going to exceed it. But anyway, it's the front of the head here. We do the forehead area, above each ear, back of the head, kind of nape of the neck, and at the trapezius. Most people who have chronic migraines tell me, oh, those areas make a lot of sense. And so it goes into 7 specific head and neck muscle areas, but there's also some pretty important nerves underneath those muscle groups too. So we're not really sure if it's the effect on the nerves or the muscles that really make this happen. So with Botox, there is a black box warning. This really creeped me out when I first started doing Botox. Is like, what are you talking about? It could spread. And what are you talking about? It could make people stop breathing. So I spent some time with the salesperson, like, all right, so how do I explain this black box to my patient? It's like those commercials, right? All these bad things can happen, and then you could die. And so really this Botox spread happened more frequently. It's actually, to my knowledge, has never happened for migraine prevention Botox in that application, but it's happened more for the heavy use of Botox in the neck for torticollis conditions. And it's happened more often in pediatric patients, and I'm not touching any kids. But anyway, so they have to know about that black box warning, right, before we go into it. It's going to need a prior authorization, so all of that history is really important to the insurance company, like what has tried and failed. And the insurance currently doesn't have a preference to go to the CGRP medication first or Botox first. So I usually, by the time they come to see me, they haven't been on either one, or sometimes they have. But the insurance doesn't have a preference which way we go. So I can often give the patient choice and, what do you want to do? And then, you have to try at least an anti-seizure, an antidepressant, and a blood pressure medicine the insurance company wants, across the board. Unless you can say, like sometimes I'll say, hey, this person has bipolar disorder. There's no way I'm putting them on any antidepressant. It's contraindicated. So you can say, that something's contraindicated, and they'll be, oh, okay. They do not have to fail a CGRP therapy, and the most common side effects, injection site tenderness, eyelid weakness, so you can cause ptosis if you do it in the wrong spot, which is not fun. Neck pain, neck weakness. There, we did it. So if anybody has questions, yeah, we got a couple.
Actually have two questions, Eva. How do you treat medication overuse headache phenomenon?
Coaching. Because sometimes if you have medication overuse headaches and you try to treat them in other ways, it's hard to get a grip on that. I'll still go there with them, but I'll be like, listen, we need to pick when are you going to detox from acetaminophen, right? That sounds weird, but when are you going to do it? Because these folks will need a few days. And it can take a while before those headaches get better. Some people will be like, no, I stopped it for 2 days and I was still having headaches. So I started taking it again. It's like, no, you have to really give this the college try and stay off of this for several weeks before, yeah. Okay.
So my other question is, you said that for people to qualify for Botox, they had to fail anti-seizure meds, antidepressants, and antihypertensives.
Yeah.
So for how long a trial on each one do they have to be on it?
Well, that's a very good question. They don't ask on the paperwork how long they're supposed to be on something. Technically, I think it's supposed to be several weeks. But what I have done with folks is, say they've come to me and they have their heart set on, a certain treatment, but they haven't been on an anti-seizure. And I'll say, well, okay, so we've got to try the anti-seizure. So I will write the prescription, you will fill it and pick it up, and then I want you to call me and let me know how it's going. And sometimes it works, and sometimes it doesn't, and sometimes you get side effects, and give me a call, and I leave it there. And so I believe it's supposed to be a certain amount of time, but the insurance companies have never backed me down to say, they weren't on this long enough. Because, to be honest with you, the only thing I can control is the prescription. And the only thing the insurance company can look at is that the prescription was filled. And whether it works or not is in the subjective environment of the patient. And I'll leave it there, because some people are just, less in love with some of these medicines with heavy side effects. But, it's good if they tolerate something to give it a good try, but yeah.
I knew that dental patients that had lots of controlled substances on it, and I found over the last handful of years, it had a decent success transitioning folks off of benzos and opiates, just because I'm typically able to partner with them on side effects that they're often experiencing that we're trying to improve. I've really struggled with my patients who are on topical. And for a lot of them, I maybe not as well versed in being able to say, hey, you're treatment-resistant depression, or you're constipation, or you're kind of broken sleep is likely related to these things. I'm wondering if you can speak to any scripts that you use to help kind of bring the patient onto your team about why, even though this is the medication they've been on for a decade, it's worth revisiting different approaches.
Yeah, it's mostly an additive sedative. It's a sedative, right? It's a heavy sedative, very habit forming, but it also runs the risk of respiratory depression, increased risk of falls and fracture as they age, and that sort of thing. So it's kind of like both opiate and benzo, those risks there. And what I have told people in the past is, hey, look, I know you've been on this a long time. You can also be driving with no seatbelt for 10 years, and you might be okay for 10 years, but you're okay until you're not. And instead of me waiting for you to have an adverse event like a fall with injury or respiratory depression and sedation and all of the things that go with that, we should be more proactive to get you off of this medicine because it's not intended for long-term use. It's like other things that we put people on and they're stuck on it forever. And so, yeah, and that's one of the things, like, have you ever tapered somebody off of an opioid or benzo who also has co-occurring like fibromyalgia? Those people, their body feels that difference in such a big way. So people who have history of migraines, again, my MA says it's fibro of the head from the neck up. They just feel the differences big time for whatever reason. I don't understand it fully, but they will have some struggles. So trying to bring a team in with that person could be helpful, and also discussing, now listen, if we get you off of this medicine and you start having these migraines again, because they might not even have migraines anymore, or they might be migraining right through the butalbital. And so, listen, if you're still struggling, once we get through this taper, then I have all these great ideas to work on your migraine pain. But 100% I'm with you. I've had those same folks, and they really, really, really will put you on that cheese grater, right? Like, yeah, it's very difficult. So I don't have great, like, magical stuff. We'll go with this person and then you.
So we're all in Maine. I have two panels of migraines that come in and confound kind of all the time. And one is changes in like hormone fluctuation, whether it is a newer onset of heavier periods after a delivery, perimenopause, that lovely 15 years, it's just gonna start whenever. Do you typically use, so two-part question, do you typically use, or do you find effective using long-term birth control, such as Mirena and what have you? I've been using that, of course, it's totally off-label, but it has been super helpful. And the other thing that I see presenting with these chronic headaches, or just a slight change in the chronic headaches, or they're used to be 3 months and now they're 7, is I have had more than 24 people be positive for Lyme disease. And I'm like, here I am completely off the ball, but you get that like afternoon fatigue, and then I asked them to take their temperature at 3 p.m, and now it's 99.5. And I'm like, well, migraine shouldn't do that. But they have been coming to see me monthly to like titrate medications for migraine. I was wondering if you had noticed that, and if people were chronic with migraines, you have a change, do you do lab work?
Well, that's sometimes. Sometimes if the change is abrupt enough, maybe, and see, I'm not their primary care provider either. So as far as the hormonal shifts, if I think that there's something there, or usually your patient will tell you that, right? They're like, I see a correlation with this. I'll often send them over to our women's health provider and say, there, see what happens here. And some people don't want to continue treating their migraines with me, with these meds, if they're figuring something else out. But yeah, I've had some people come in that, things seem weird and, doesn't really match up with your classic, just gradually increasing migraines, that I'll either refer back to their PCP, or I may even get some inflammatory markers or something on them. So, yeah, so sometimes for me, but if I were their primary care, yeah, I'd be looking at it more comprehensively.
I have two questions. One is going back to the cheese grater topic, and I'm wondering if there's a level at which you are comfortable dispensing a number of butalbital tablets monthly.
Oh, no, typically, if somebody comes to me, I don't start butalbital. I have from time to time, I will, if somebody is having some sort of adjustment or crisis in their pain, I may use butalbital, but I'll give somebody like 8 or 10 pills, like an acute prescription, if I do choose to go there, which is rare. But if they come to me already on butalbital and the job is going to be to taper them off of that, I typically will make a 10% reduction once a month or so, because I'm super slow and I'm okay with that. But yeah, like it's a controlled substance. I mean, if you're worried about misuse or overuse or et cetera, you can make sure that you're doing your monitoring that you would do with an opioid as far as med counts and that sort of thing, and you can also get a urine screen and send it out for your,
But you want them off of it.
typically.
I mean, I want them off of it, but it's a hard fight.
Oh, it is. It's a
It's
wicked.
all inherited. I'm not
Uh-huh.
certain.
Yeah, and it's like, I tell people, if you came to me as a brand new baby, I wouldn't put you on these things because they're not safe, but it's how we used to practice. It's how people used to practice. It's old school, but it's not indicated anymore. And we've created this situation where you're really reliant on this medicine, and you're also afraid to get off of it. Of course you are. You think you're gonna be worse. So yeah, it's a bugger, but I don't have like a number that, or, sometimes I'll negotiate with somebody and be like, okay, so we'll get you off the everyday diet. And I want you to be able to survive a whole month on 15 pills, or whatever, come up with a number together. And if that's where you wind up, huge improvement, huge improvement. And then they may even kind of peter off. Like I've done that with, there was somebody on Ambien. That's another one, right? That's hard to get people off. And she would get herself so anxious in the taper that she would get a migraine and she wouldn't sleep and all. And so we settled on, I'm like, okay, if you have 10 Ambien in a bottle sitting on the shelf, will you feel better? She said, yes. So she like literally, I think she gets a prescription for Ambien every 6 months. She hardly ever takes it. So it can end up being that way if you get that everyday diet out of there. And so if it makes somebody feel better that they're gonna have 15 butalbital on the shelf, sometimes that really helps them, but wicked hard. I feel your pain every day.
I have one more question.
Yeah.
I'm thinking about a patient who's had 40-year history of migraines, and she's seen multiple headache specialists. She's been hospitalized. She tried probably every drug multiple times that came through your
Mhm.
slideshow. And I'm
Yeah.
thinking like, is there a way to think about like migrainer zebras or, like alternate diagnoses, and what have you seen as the explanation for these patients? Because you've probably
Yeah.
seen some.
I have one lady who's a huge success. I'm so proud of her progress, and another lady that's kind of, and what has happened is both of these patients, one of them basically spent 10 years in bed. And prior to seeing me, she said, I've tried everything. I've had Botox injections, etc. And then when I questioned her more, the Botox injections she got were not the protocol ones, right? They weren't done precisely that way. So I said, well, we can kind of pretend you've never done Botox before. So we restarted that. And then before I knew better that the insurance doesn't like to pay for both Botox and a CGRP monthly injection, I prescribed that too. Because the Botox worked pretty good, but we weren't quite at goal. And when she got put on that dual therapy, this woman gets out of bed, she's she paints, she's an amazing human being, and it's been pretty nifty to see that happen. Second person, I collaborate with a neurologist on the second person. She gets Botox injections from me. She's on CGRP medication and then a couple other like fancy schmancy things through neurology, and she's still a little bit like, not super, although she's seeing benefit from the Botox that I'm doing. So really, if one thing is not working, it's like stacking up multiple things that are tolerated. And that almost always needs to fall in with neurology somewhere, because insurance is going to be like, you're not a neurologist. And it's not that we don't have the knowledge, but the insurance company, it's their job to put up those barriers. So no magic bullet there. I wish there was.
I'm gonna call it because we're 10 over.
Oh my God, sorry guys. Thanks for staying.